Good morning and welcome to an episode of Fertility Talk. This month we are honoring World Fertility Day. We're making it turning it into a World Fertility Month, and just because there are so many talks that needs to be done, and we just decided to throughout the month of November we're going to be doing this. And our first speaker we have is Dr. De Jongh, Dr. Skye de Jongh, and she's from Vitalab KZN or Vitalab KZN. Thank you for joining us again, Dr. De Jongh.
Thanks, Leanne. It's always a pleasure to be on these talks with Fertility Solutions and to educate our patients and hopefully give them some more information about their bodies.
Thank you very much. So today's topic is how does PCOS affect the patient's chance of falling pregnant? And we're going to get into our first question is what exactly is PCOS and how common is it among women of reproductive age?
So PCOS or PCOS or polycystic ovarian syndrome is really common. 1 out of 10 reproductive age women are affected by this. And many people can go their whole lives without being diagnosed. So
Mm,
it doesn't necessarily mean that because you have PCOS that you are going to struggle with fertility. And it is quite a hectic diagnosis for some people because they immediately think, oh my gosh, I won't be able to have kids if I have PCOS.
mm,
But that's definitely not the case. And there's a whole spectrum of PCOS, and it goes from very mild to very severe. And of course, the treatment will be different for each person. So, PCOS is a genetic condition where you've inherited this predisposition from someone in your family, and it doesn't have to be your mom.
mm,
So, it could be on your dad's side, it could be, an auntie on your mom's side, it could be anyone. And often it's someone who has diabetes in your family because that's one of the complications. So it's yeah, it could be from anyone. And so this is something that will be with you for life. This is not
mm.
something that you can cure, but it is something that you can manage.
Yeah.
So basically, when you have PCOS, your LH level, which is a hormone coming from your pituitary gland in the middle of your brain, is very sensitive to insulin. Insulin is a hormone coming from your pancreas, and its job is to grab hold of glucose, which is sugar, and take it from your blood and put it into your cells so your body can use it for energy. Now, when you pick up weight or you have an unhealthy diet or you have a high carbohydrate diet, your insulin level starts to go up. As your insulin level goes up, it pushes your LH level up. Now, LH is supposed to only be released in high quantities around ovulation. So if it's high, your brain and your ovaries think, oh, we've already ovulated. Cool. But in fact, you haven't. If your LH levels are high all the time, then what happens is your brain says, oh, we've already ovulated. We don't need to start the ovulation process. And so it doesn't send FSH. And so
Yeah.
your FSH remains very low. And so you just don't ovulate, or you ovulate at a weird time. So this is how patients with PCOS will present with irregular periods or with no period at all. Um, the other component to PCOS is high testosterone, and this is often referred to as androgenic features. So this is the features that are associated with high levels of testosterone. Now, if you imagine you in your body, you only have space for a certain amount of LH. So imagine a jar, and once that jar of LH is full, it sort of spills over into the testosterone jar, and that starts to fill up. So once your testosterone is high, it increases the oil in your skin, and it increases the incidence of acne as well as abnormal hair growth, sometimes on your lip, on your chin, between your breasts, on your tummy, your thighs. And so those are the features. Now, to diagnose PCOS, you need 2 out of 3 criteria. This is called the Rotterdam criteria. So the first one is the irregular periods. The second one is the androgenic features. That's the irregular hair growth and the acne. And then the third one is polycystic ovaries on ultrasound. Now, this is a tricky one because often patients who are very young will be misdiagnosed with PCOS. Because they're young, they have lots of little follicles on their ovaries. Now,
Mhm.
I know the word cysts is a bit of a misnomer in the name polycystic ovaries because Actually, we're not talking about cysts. We're talking about follicles. Follicles are normal little bubbles in the ovary that contain an egg. Okay. And what happens in PCOS is because they're not ovulating regularly, they all sort of crowd around the outside and they're like, guys, which one of us is ovulating? And there'll be like 30 of them on the ovary instead of only 15. And so you often get what's called a string of pearls effect. So you get lots and lots of little round follicles around the outside, so it looks like a string of pearls. But sometimes this can be misdiagnosed in young people because they're young, they just have lots of follicles. So actually, in an adolescent, we don't use those criteria. We don't include the ultrasound diagnosis. We just need the other two. But in reproductive age women who are trying to conceive, generally we want to see the ultrasound findings and then the irregular periods or the androgenic features. And yeah, so basically the PCOS is a collection, it's a syndrome of these hormone imbalances. And in order to manage it, we need to get those hormones back in balance.
Okay, perfect. Thank you. Our next question is, how does PCOS impact a woman's ability to ovulate and in turn her chance of falling pregnant?
So, not every lady who has PCOS will have problems with ovulation
Yeah.
and might not have a problem with ovulation every single month. So, anyone who says it is impossible for you to fall pregnant if you've got PCOS is wrong because every now and then you will have a breakthrough ovulation and you might conceive if you're having regular intercourse. But it is more difficult to conceive because your periods are irregular. So, timing when you are going to ovulate, knowing when you're going to ovulate and having intercourse at the right time is tricky. So in some patients, yes, they'll ovulate normally they'll have regular cycles. In other patients, if they're having irregular cycles, they may ovulate on day 20 instead of day 14, and that might be difficult. And then in some patients, they may not ovulate at all.
Mm.
And we've got quite a few methods to help with that.
Okay. Our next question is, are there different types of severities of PCOS, and do these influence fertility outcomes differently?
Definitely. So some patients will just need help with timing. Okay, so that the patient who is ovulating on their own but just isn't coming right with conception, all they need is for me to, number one, we need to optimize their weight. So optimizing your weight will bring your LH down by bringing your insulin down and therefore your testosterone as well. And so just by bringing down your weight and monitoring your follicular growth, so monitoring the growth of that one follicle that's going to ovulate, and then we tell you, all right, cool, go home, have intercourse, that can do the trick. So that'll be with your mild PCOS.
Mm.
In more severe cases, you might need help to ovulate. So we might need to give you some tablets to induce ovulation, scan you, and then tell you when to have intercourse.
Mm.
Some patients' ovaries are so stubborn, they haven't been listening to your brain hormones for such a long time that they don't respond to that medication. So the medication I'm talking about is called, it's an aromatase inhibitor or clomiphene citrate. The latest evidence suggests that an aromatase inhibitor like letrozole is superior to clomiphene citrate. So we generally use aromatase inhibitors, and basically they decrease your estrogen, which sends a backdoor sort of message to your brain to say, please send FSH to the ovaries. And then your own body's FSH stimulates the ovulation. But in some patients, they're just so stubborn, they don't listen to your own body's FSH, and we have to give an injection of FSH
Yeah.
in order to get ovulation to occur. So that's the next sort of step up, is that we can induce ovulation, but more directly with an injection. But in some patients, even that doesn't do the trick, and the ovaries are so stubborn.
Yeah.
And in those patients, they end up needing IVF, which is high dosages of FSH and sometimes the addition of LH, depending on what their baseline LH levels are, to get all the available follicles for that month to grow.
Yeah.
And then embryos and put one back. But the issue there is that egg quality becomes a problem. The more severe your PCOS is, the more likely that those eggs are not going to be normal, despite your age.
Wow. Thank you very much. Um, what are some of the most effective treatments of or lifestyle changes that can improve fertility in women with PCOS?
So the first thing is trying to make sure that your BMI is between 18.5 and 25. So to get there, I always suggest that my patients see a dietitian who has a special interest in PCOS, who can give them guidance on the right foods for their condition, because this is going to hold them over for the rest of their lives. This is not just in an effort to conceive, this is in an effort to balance their hormones and keep them healthy.
Yeah.
And most of that is about choosing low GI options to try and keep their sugar levels down, to try and keep their insulin levels down. Um, other methods that we can employ for weight loss are obviously exercise. So with PCOS, 75 minutes of high intensity exercise is recommended to try to obtain a healthy weight, or try to obtain and then maintain a healthy weight. So 75 minutes, what's that, like less than half an hour, 3 times a week of high intensity exercise can really go a long way. And then if patients are really struggling with their weight loss, then some help using a GLP-1 injectable can also be really helpful. The second thing is to put them on a vitamin called inositol. So the evidence suggests that a ratio of 40:1 of myo-inositol to D-chiro-inositol is helpful in keeping insulin levels down in PCOS patients. And some patients who are not regular, when I put them on inositol, suddenly their period starts to become regular, and that's all they need, you know.
Yeah.
So that's always my first line is lifestyle factors plus a vitamin. And that there are a lot of different vitamins, and most of them contain coenzyme Q10, which is really helpful for egg quality, as well as folate, which is going to prepare the body and help to decrease neural tube defects in the baby. So those are really good core things. And then we can go into ovulation induction techniques and IVF later on if necessary.
Okay, and if I may ask, what about metformin or glucophage? Is that still being used? Or
So
sorry to
not
bring
so
that up.
much anymore, there was a lot of we used to use it in the past to lower insulin levels, and it
Yeah.
does work quite well to lower insulin in type 2 diabetes. Um, but personally, I found that patients who have very high insulin that would require metformin are now choosing to use a GLP-1 to obtain the weight loss, as well as lowering the insulin. The metformin doesn't really help you much with weight loss. And it certainly doesn't assist with ovulation induction on its own. It is not recommended to use metformin alone for ovulation induction.
Yeah.
But if the patient does have high insulin but doesn't need weight loss, then metformin would be a good option to
Okay.
add.
Thank you very much. Um, can women with PCOS conceive naturally, or is it fertility treatment using required? Is fertility, yeah, do we need fertility treatment?
They definitely can. So even with irregular periods, you could get lucky if you happen to have intercourse on the right day. But it is harder. So a lot of that's my aim with most of my patients. I want to treat them about their bodies, get them as healthy as possible, and get them to conceive on their own. So I do have many patients who just conceive with the dietary advice. With the vitamin, and then also just education about how your cycle works, when is your fertile window, and how often should you be having intercourse, and those kind of discussions. And generally, if you have mild PCOS, then you can come right on your own and you don't need me at all.
Okay, thank you very much. How important is early diagnosis and management of PCOS for long-term reproductive health?
So it's really important. So not having your period for long periods of time can be really dangerous.
Yeah.
So if you are going months without your period, that increases your risk of getting uterine cancer later on in life. Obviously, it increases your risk of infertility, but it also, having very high insulin levels like that can increase your risk of getting diabetes, as well as gestational diabetes when you are pregnant, which can have long-lasting effects on your baby. So it's important to get diagnosed early, and having an irregular period, which means having a cycle that is longer than 35 to 38 days, and that's, changing from month to month, or if you're skipping periods, you really should come and see your gynae to get it under control, whether you're trying to have a baby or not, because it can have drastic effects on your health.
Okay, thank you. Our very last question, Doctor, is what message of hope would you share with women struggling to conceive because of PCOS?
The message I would give to ladies who are struggling with PCOS would be come and see me.
Mm.
Let's balance your hormones. Let's
Yeah.
get you happy. Let's get you healthy. And sooner rather than later, you'll end up pregnant.
Perfect. Thank you very much. That's Dr. Skye de Jongh, and she is at Vitalab KZN. If you'd like to get hold of her, you can visit their website. You can also find all the details on our on fertility solutions as well. And you can also DM me or email me, and I'll give you Dr. de Jongh's details. Thank you very much again for joining us, and it's always a pleasure speaking to you, Dr. de Jongh.
Thanks, Leanne.
Thanks.
Cheers.
Bye.